I'm going to take a very shallow dive into some things that come across in oncology and in more general talk as well, and a very specific example for the second half of the talk will be brachytherapy as well. First of all, a little bit of history, once I get my next slide on. The hospital was first developed as a base hospital for the Americans during the Second World War, and is famed that Glenn Miller's second last concert was at the hospital before he disappeared in a plane crash. No omens there. And also Old Road, where the hospital was found, is the old London to Oxford and on to Stratford upon Avon route. So that means that I share my commute with Shakespeare, which I find fascinating. We have potholes, bandits, and I think Shakespeare had it pretty bad in his day as well. The hospital now on site is a PFI managed equipment scheme hospital. You had an oncology hospital, and I was asked to do talks on a talk on oncology. Sort of, you do oncology things, to talk about oncology thing. And got me thinking about, well, what does that mean, and what have we got that comes in that category? Well, of course, you've got the specialities of oncology and hematology in the radiotherapy department, and then the specialities that you'll find on site, such as breast, chest, renal, urology, and all the prostate work that comes with that, upper and lower GI, diabetes and endocrine. And then, of course, we've got the workload that comes from our friends at the John Radcliffe part of our trust, neuro-oncology, gynae-oncology, ENT. So a general mix of patients and different things that you'll come across in that workload. So I thought I'd divide this first part into sort of where do these patients come from and why do they keep on coming back? And the most obvious starting point I thought would be screening. So that's family history. For example, BRCA carriers, breast patients who would come back over every year for quite a long period of time in their life. And once again, we have all the comparisons that come with that. Screening patients give you a really good example to see how things have changed over time. And you've got our air recon DL images, the current ones at the top compared to the ones at the bottom, indicating how things will change over time. One controversial thing is that I've actually called them patients because our breast family history booking team call these patients clients. If you want to have a debate about that, please feel free. I've looked at it in the dictionary and you could take it both ways. Here's a bit of a close-up of that particular group of images. There's our old ones, and breast is not particularly benefiting from air recon DL, but I think you can see what kind of changes you're getting for no cost in time, as we've already talked about, to improve image quality. Another genetic example would be Li-Fraumeni syndrome. Now this is a syndrome where patients have a genetic predisposition to cancers. If you're male, you have a 70% chance of developing it in your lifetime. If you're female, you're looking at a 100% chance. Osteosarcoma is one source of this particular, of the cancers, but it could be anything, breast, head, and pretty much anyone through. A feature of Li-Fraumeni syndrome, if you'd like to call it that, is that you are more at risk from radiation. Radiation sensitivity is quite high, hence MR being a beneficial set of images to take to screen these patients. One of the parts of the body that's sort of falling into two categories here is the prostate, because it's almost now becoming part of the screening program. A recent UCLH study sort of showed that they were able to start modelling for a screening service. That could be something where you'll end up seeing the vans in your local shopping centre offering scans to all and sundry. So MRI in prostate is falling across this barrier between pre and post, between screening and into my next category, which is diagnosis and symptoms. Obviously, MRI, it comes with these patients. They have lower urinary tract type symptoms, or the PSA result has come back that way. Another example would be in the neck, swallowing difficulties, and then you're looking at getting these types of images to be able to diagnose as opposed to stage, which is what you end up doing with these patients, such as the lymph node the necrotic lymph node that you're seeing on this particular patient here. Good example of staging as well, as I said, which is our next category. A big shout out to anyone who's good at getting their angles correct when it comes to scanning the rectum, getting nice angulation so as you're perpendicular to the tumour, and also getting that presacral node collection or the presacral space in parallel so as you can get some really nice images to prove what's going on in that particular area. Obviously, this then means that we're looking at getting reproducible images and quality images in order to aid with the TNM classification of these patients so as we can tailor their treatment to them, aid our prognosis of them, and also get a relatively high level of reproducibility where we can. The fourth category that I've gone for today is to confirm and categorise. Bone is an example of that. You may have had a PET scan that indicates that there's an issue that needs more characterisation, and MR will cover that. The example I'm giving you comes from our suspected cancer or scan pathway, which is a pathway that allows GPs access to a CT in order to have nice imaging or to be able to diagnose a patient who just doesn't seem right. It could be weight loss, it could be fatigue, someone who they haven't been able to get into any portion of a tertiary system. These patients are interviewed over the phone to have a medical history taken with a radiographer or a nurse. They have a CT, neck, chest, abdo-pelvis and bloods, and then get referred into an urgent pathway should these scans discover, or the results discover something that needs further action. So this has allowed troublesome patients, in the nicest possible way, to find a route into the hospital system. And NHS England have, I think, are mandating that this will be rolled out, so you may well find this coming to your trusts and closer to you as you go along. My example, just a simple example, they've had the CT scan up there in the top left. It's shown a lesion, and then we're imaging further down the track to try and characterise what will probably be a metastasis, or will be a metastasis. This patient will go on for treatments such as ablation or whichever is most appropriate. So then the next part of it, of course, is why do the patients keep on coming back? Obviously, the screening patients return year after year after year. The next classification would be response and surveillance. The response will be part of when I talk about my brachytherapy patient shortly. But also surveillance gives us a chance to see imaging of patients that return year upon year again. Here's my example here of a rectum patient once again, and you can see the images on the left indicating previous versions of the scan and now what we're getting with Air Recon DL. We haven't had too many problems with our radiologists from that point of view as far as getting used to these type of pictures, but there is some talk of the patients being difficult to convince them that those little dots that you see all around in those patients on the old images aren't actually there. If you were to cut that patient open and have a good look at them, you wouldn't find that there's tiny little dots all through there that are actually physically there. The patient is just in those bits of the body, just full of fat. Obviously, a more general category that we would have is relapse, recurrence, spread, and symptoms. Patients that come back because of back pain and need to be investigated in case it's something to do with their cancer. My example for this is this chap who had signs in his bloods of being a myeloma patient, was under investigation in the general sense for myeloma, but his GP had treated him for disc pain as a disc patient, and he was referred for physio, had a lump developing on his back as well, but hadn't been referred in. He finally saw a haematologist, came to see us. He drove in himself, and as you can see from these scans, he had a cord compression that was not leaving too much CSF around his spinal cord. Oh, actually, and to talk about those patients as well, our cord compression protocol, we had varying versions of that as well, depending on from the full quality one down to the patient can't tolerate much at all. we're finding ourselves hardly ever using anything but the full quality one because it's actually quick enough for everything we need. Obviously, there are versions for for a patient that's not going to tolerate anything at all, but to be honest, we're almost getting what we need covered in the localizers for that type of patient. Another recurrence type patient is a poor patient who would end up with a tumour based on their radiotherapy treatment, so a sacral tumour that has been developed because of their radiotherapy. That's another type of patient that we find ourselves having as well on occasions too. I'm going to skip over research because you could do a whole talk on it. Suffice to say that you end up with patients coming back to you for extra time points or having novel techniques as part of their scanning, and also reproducibility, once again, is an important part of those patients. If I could talk for a little bit longer now about treatment planning and some of the examples I've got of that, and I'm talking about a little bit of external beam radiotherapy during this and also brachytherapy. The obvious thing, why MRI? Why do we need MRI for these patients? Obviously, we get a greater delineation of the tumours, normal tissue, and also the normal tissue to avoid that normal tissue, and to get some good treatment plans so as we can avoid the radiation to that area. The typical example you may see is the CT on the right, and the exact same patients, same slice on the left, and you can see it doesn't take much to see where the differences lie and how MRI is able to help find all the structures you need and get closer to that type of coverage. What our radiotherapy departments would like, in many instances, of course, is a dedicated MRI in the treatment position. Using a flat table, for example, standardized immobilization, be that knee pads or a specific type of knee pad, or suspended or restricted respiration for the upper abdomen, a full bladder or an empty bladder or a medium bladder. But of course, standard coil designs don't allow that to take place. It's usually not overly conducive to a treatment position, so we have to make do. Stereotactic radiosurgery is an example of that. They would love us to be able to scan in this frame arrangement that we have here with their mask across them and be able to do them in our standard head coil or better. It's not possible. Anyone who knows what a standard head coil looks like would know that fitting heads into one of those wouldn't really work, and you would be upright and be above. One thing we're looking at is when it's on the market is this particular coil, which allows you to wrap the coil around the patient using air coil technology and get pictures closer to the area of concern. So there's a prototype version there, and you can see compared to the position that our radiotherapy department would like, we're able to get coverage of that particular area by using that type of coil. What's the benefit? Obviously, you've got increased treatment confidence, and you're able to treat smaller lesions sooner. An example there, pre-treatment on the left, post-treatment on the right. So I'd like to talk for a little bit longer now about intrauterine, interstitial cervical brachytherapy. Is mostly interstitial. It's a type of radiation treatment delivered directly inside the body. Obviously, our aim is to give that highest dose as possible to the tumour and minimise the dose to anything else. We're making use of inverse square law, of course. You knew it would come back to help you at one stage. You're trying to have that radiation very close so as it drops off very quickly as well. So we're offering that soft tissue detail to complement what the planning CT offers in so-called perfect geometry, shall we say. The two particular types, on the left you've got the interstitial version using the device that you can see there, and then inserting needles up through the ring at the end into the tumour and into and around the tumour so as we can deliver radiation directly. The intrauterine version uses an applicator and allows you to do treatments closer to the surface of the uterus, shall we say, and surrounds, and in such examples. But obviously can't surround the tumour in exactly the same way, but is better in certain situations. Cervical cancer, we're talking, according to CRUK statistics, we're looking at 3,200 cases a year, 850 deaths, 50% survival rate at 10 years. and sadly 99.8% are preventable. One interesting thing to take into account is the numbers aren't particularly going down despite screening, despite vaccines coming in as well. We're probably scanning around about 1 patient a week, so we're looking at about 50 to 60 patients a year still coming into the system needing treatment. The diagnosis comes from cervical screening and also from symptoms, so be it abnormal bleeding, pelvic pain or weight loss. The MRI is usually the primary form of diagnosis at that particular point, and the patients are having PET scans in order to stage more distant tumours. An example patient that I'll sort of slip in and out of a few times during this talk, they've had bleeding for about 4 weeks. On examination, it looks suspicious of cancer. They had a biopsy and it was a squamous cell carcinoma. There was a focus centred on the cervix, as you can see, and there was parametrial invasion. So what that means is, of course, that with the parametrial invasion, the staging becomes 2B. And corny joke time, I'm afraid, but because of that, of course, to be or not to be is the question. A 2B and above is brachytherapy, below 2B is surgery. So I've got Shakespeare in again somehow, I don't know how. Following on from that, this particular patient had no avid or nodal metastatic disease, and so we moved on to treatment for them. Prior to brachytherapy, they would have concurrent chemoradiotherapy, external beam for 5 days a week for 5 weeks, chemotherapy as well, and they have cisplatin for 5 weeks. Across that period of time, it's no walk in the park for them. There are plenty of symptoms as well that come with that. Usually at around about week 4, we have a pre-brachy planning MRI, so as we can assess the tumour and see what kind of change has taken place post-treatment, make sure there's no signs of spread, and see what the remaining tumour volume. So here's our pre-image, scanned elsewhere at a different trust, might I add, and there's our images at 4 weeks. So you can see that the tumour volume has reduced, but not totally. We're looking in our images of getting a nice sagittal T2. One of the Air Recon DL benefits is that I had a radiologist who preferred the cube for the sagittal T2 in order to get very thin slices, but preferred the contrast of the normal sagittal T2, and we were doing both images. I've managed to now, with Air Recon DL, be able to get down to much thinner slices on my normal sagittal T2 with higher resolution and have just the one set of pictures in a quicker time than that previous sagittal T2 by itself was as well. We do axial T1s and T2s straight in order to monitor that local disease. That is, we want those, have the comparability of those images further down the track or at that particular point wherever possible as well, so as we can make a direct comparison to see if there's been any other disease change, say for example nodes or in the bone, anything else that might be possible. The DWI, we're using the Muse sequence for that. Mostly on our 3T, we've been using 3 millimetres slice thickness and up to 4 or 5 depending on the case for the 1.5. You also then, of course, do the axial obliques, the T1s and T2s, and the DWI along the short axis of the tumour in order to be able to give the best possible information for the radiotherapy planning, of the brachytherapy planning. Once again, pre-tumour on the left and post on the right, and our radiologist has report that there's, as you can see, that there's some residual tumour left, slightly more marked on the right-hand side, and it appears to just extend into the lower uterine segment and around about there. The ADC maps of that particular patient as well, just another way of giving you an indication of how the tumour has shrunk and also where the tumour may well be. Moving just to the side a little bit on this, we've also got the intrauterine version of that, which is the alternative pathway. This is a scan, we on occasion scan these patients with the applicator in situ in order to assess whether it's possible for us to treat that particular tumour just using a device such as this applicator. One of the benefits of having a second table on our 1.5 Tesla is the patients can be prepared, and we have a more comfortable event for the patient because we don't have to transfer them during that part of the procedure. And you can see that an area such as this can be planned and given a radiotherapy dose, a radiation dose that will treat that particular tumour. Sometimes it comes down to these images that decide and attempt with the applicator will give an indication of whether it's possible to do that particular type of tumour in whichever method. Getting back to our interstitial pathway, for these patients, the patients are having a theatre procedure. Hopefully it's a spinal anaesthetic procedure as opposed to a GA these days. It was a lot harder for us to time our scanning during the day when it was GA because the recovery was ad hoc and patient dependent. We're now a lot more reliable since they've been able to go to the spinal method. Our radiologist goes to theatre and offers an ultrasound guidance for these, for the intrauterine section of the tube, which is the section that goes up there towards the uterus, into the uterus. Also, then needles are inserted. You can just about see an example of that there on the, I can't get that mousy bit to work, is it there? There it is. So you can see a needle coming up through across there as well, and those needles are inserted off a template on this ring, which allow us to surround the treatment target with the needles. We're working in close contact with radiotherapy. The CT scan and the MRI scan that these patients have post-op gets timed depending on who can fit them in well enough. So we're working in a good teamwork with our friends in radiotherapy on this. They are sorting out the Buscopan and the safety forms prior to the patient coming for treatment, prior to their operation. They're doing that on the ward beforehand. The patient has pain relief, obviously. They have a patient-controlled anaesthetic pump that gets disconnected just before the scan. Obviously, the patient has to remain supine for 3 days of the procedure, no higher than 15 degrees. So it's a pat slide technique and a table out technique in order to get the coverage as well there too. The device is, you'll be pleased to know, MRI safe. It's made of PEEK plastic, which is clavable so that it can be reused, and it doesn't cause any artifacts on the imaging, as you've already seen. The post-procedure MRI, we're using that sagittal T2 again. It says thin slices and good coverage of the unit of the area. We've got the axial oblique. Angling is a lot easier in this situation because we're able to see where the ring template is coming off and get the pictures. You can get a good idea from here how much the uterus is moved by the insertion of the device. Radiologists would also like me to point out how difficult it can be to get the ultrasound into position when everything is being moved like that as well. And you'll also see packing. There's packing as far as the around in this area here as well in order to make sure the device stays in position for the 3 days that the patient has it there. So there's an example of how that angle is, and we're looking at coverage a little bit beyond the uterus as a rule, because you can end up, the needles that they insert can go up and beyond that particular coverage as well. Interesting that T1 is the best image for being able to see these needles clearly. It doesn't often offer, as you would expect, as much of the diagnostic information, but it certainly helps and is almost as good as the CT is from the planning perspective to be able to be certain about where those particular needles are going. And there's your T2 image giving a better indication of where we're covering the tumour as well. And just that area that we've been most interested in is coming in on that particular site there on the right-hand side. Our MRs, as well as the CTs, are used in the planning of these patients. As you can see, the MR is being utilised in order to make that treatment plan to cover the area that we're interested in, and they were able to work out whether the radiation source will be able to get close enough to where the coverage is on there. You can see how the CT does offer a level of conspicuity, I guess, of the of where those particular needles are going to as well, and you can see it also outlining other structures that they're planning to avoid as well. So part of their planning is you get this picture such as this here. We can get a close-up look and you can see those tiny little things that look like grains of rice. And those are the particular points where they plan to move the treatment source to at any particular time during the radiotherapy treatment. You can see little sections there, and they will move up those needles and go to those particular points. I'll explain that better here. This particular machine, the machine you see on the right there, is called an afterloader. It contains that tiny little thing that you see at the bottom. That's 3.5 millimeters by 0.6 millimeters on the end of a guide wire, iridium source that lives in that box and then travels up those wires from the box and into those particular treatment locations, using a technique a little bit like you can see on this picture here. So the patient will have had all the recovery, had their scans, back to the ward, and then will have their first treatment at a particular point during the day. You can see there, looking back at those pictures there, each particular location will have a treatment at any particular point, and will the guide wire will take that iridium source to those particular points, treat, retract, and then come back again. You can get a coverage of around about a centimetre around that source, and it's usually 20 minutes or so for a treatment on a particular day, but it can be double that because by the end of 3 months, the source will have decayed and will need replacement, and they have to calibrate each time in order to be able to work out make sure the dose is maintaining the level they require. A more complicated case that you can see here, a much more advanced tumour. You can see the DWI image and is indicating how it goes a little bit further. So the template requires a second row of rings in order to treat the tumour. It seems, when you first come across these images and you see how far out to the side these needles are going and how they don't seem to be going into a particular tissue, that seems like some kind of craziness. But it's totally normal for this particular procedure. That's what they do. And even the chance of perforation into bowel is treated as something that just requires antibiotics as opposed to what seems at first light to be a big disaster. And so when someone comes to work with you and they see that for the first time, they think they've got something major on their hand, but it actually doesn't seem to be as much of a problem as you might think. And also good to point out, of course, that how well the air coils are tolerated for this particular type of exam. How easy it is to just rest those coils across the patient with no extra weight or extra discomfort for the patient. There's the coverage that you'd get for that particular type of tumour when it's in the radiotherapy planning software as well. So the patient's gone through the system and they will have radiotherapy treatment at the end of day 1, and then twice on day 2, and then return to radiotherapy for one more treatment on the last day with the applicators removed on the ward as well. So there we are. We've talked about through there, we've got to the end of where all the treatment planning gets to. I'm embarrassed to say that I also went to ChatGPT. What I asked for was 6 lines to describe MRI in the style of Shakespeare. And this is what I got. And I think I could read it out to you, but I think you can enjoy it yourself. I don't have my tights on to read it while holding a skull. I'd like to thank you all for your time.